Thanks, class, for returning. I think this is going to be a really great lecture. You had the foundation set by Dr. Miller last week with virology, but today we're going to be delving into a really, really exciting topic with Dr. Sedaghat. So, smell and taste are crucial to our daily lives. Everything from eating to exploring new environments and making memories involves these important sensory functions. As you know from your pre-class readings, loss of the ability to taste and smell is a uniquely prevalent symptom of COVID-19. This week, Dr. Ahmad Sedaghat will lead us in a discussion on the fascinating science behind why a virus we cannot even see can cause us to lose our ability to smell and taste. Dr. Ahmad Sedaghat is the Director of Rhinology, Allergy, and Anterior Skull-Base Surgery at the University of Cincinnati in UC Health. He's a world-renowned expert in inflammatory diseases of the nose and sinuses, as well as endoscopic sinus surgery and anterior skull-base surgery. Dr. Sedaghat earned his Bachelor of Science in Biomedical Engineering from Columbia University and both his MD and PhD from Johns Hopkins University School of Medicine. Dr. Sedaghat completed his residency in otolaryngology, head and neck surgery at Harvard Medical School, and completed a fellowship in rhinology and sinus surgery at the Massachusetts Ear and Eye Infirmary. In addition to his work as an anterior rhinologist and anterior skull-base surgeon, Dr. Sedaghat is one of the nation's foremost experts on the sinonasal pathophysiology and symptomatology of olfactory dysfunction in COVID-19, as well as the effects of olfactory dysfunction on mood and anxiety following COVID-19. As of this afternoon, Dr. Sedaghat and his research group have published 5 manuscripts related to COVID-19 in major academic journals like Laryngoscope, and have been featured by major news outlets such as USA Today, US News and World Report, and Forbes. Dr. Sedaghat, thank you so much for leading this discussion on loss of taste and smell in COVID-19, and I'll let you take it from here.
Wow, thank you for that great introduction, Scotty. I really appreciate it. Well, I'm grateful to be here, and this is, for me, one of the funnest parts of my job. Being able to directly reach out, lecture, and teach upcoming future specialists. So with that, why don't we get started? So I'll be speaking about loss of one's sense of smell and taste during COVID-19. I'm fine with answering questions throughout the lecture. Scotty, if you want to raise your hand or turn on your video whenever someone asks questions, I'm happy to answer them in real time. So I think part of what makes this such an interesting thing to think about is just reflecting on the history of COVID-19 and how this all came about. Scotty and I were talking about this for a few minutes before the start of the lecture. So we're all probably quite familiar with the history of COVID-19 and the fact that it first started to become something that people were aware of out in China in late December of 2019. And then things very rapidly spiral out of control from there, being declared a global health emergency in January of 2020, and then being declared a national emergency by President Trump on March 13th, 2020. Now, I remember this day very well because it was Friday the 13th, and I was in clinic that day, and I was trying to get a hold of my office staff just for random administrative things, and I couldn't get a hold of anyone. And I was kind of getting annoyed. And then all of a sudden I realized, holy smokes, the world was turning on top of its head. And so that day sticks out in my mind very clearly. Within a few days after that, we started to get some idea that the loss of one's sense of smell was associated with COVID-19. Now, in our rhinology community, we have bulletin boards, online message boards, just like everyone else. And this is a message that was posted by a French otolaryngologist a few days after things really started to take off here in the States. Just asking our community, hey, has anyone else seen this? We have started to notice a lot of patients presenting with decreased sense of smell. Very quickly, there were responses from other rhinologists from around the world mentioning that, other rhinologists in areas where COVID-19 was taking off, Iran, Italy at the time, you may remember, were early hotspots for the disease. these individuals, these otolaryngologists, these rhinologists were also hearing about this. Iran, Italy, South Korea. So very quickly, it became apparent that this was a part of COVID-19 and one of the disease manifestations. Very shortly thereafter, major organizations, the American Academy of Otolaryngology Head and Neck Surgery, the British version of that, ENT UK, as well as the British Rhinologic Society, put out recommendations suggesting that new onset anosmia and smell loss be considered an indicator of COVID-19 until proven otherwise. And they made recommendations, I think more importantly, that this symptom should be included in the screening for COVID-19. You may remember early on, all of the screening questions were focused on symptoms like cough, fever, shortness of breath. And these societies made the recommendation for good reason, which I'll talk about shortly, that anosmia and smell loss be included in the screening for COVID-19. So before we get into the meat of the lecture, I think it's always important to really think about why is it that what we're talking about is important? Why should we be here tonight? Why should we care? Why should we listen? You know, olfaction on its own is important for a number of reasons. It has a significant effect and plays a significant role in our quality of life, from being able to sense pleasant substances, stopping and smelling the roses, for example. So much of what we do with food and the quality of life benefit that we get from food is related to olfaction. Flavor, which I'll talk about in just a bit. Just being able to cook because you can smell the ingredients that you're putting into your food. And then there's so much in terms of social interaction that goes around eating that is involved with olfaction as well. Something that we don't often think about, but so much of personal hygiene is also related to olfaction as well and directly contributes to our quality of life. I also mentioned on here under quality of life, but maybe you can think of it more in terms of survival, is our ability to sense noxious substances, dangerous substances, things like smoke, gas, and spoiled foods is related to olfaction. And then what's also, I think, going to become apparent in terms of the importance of olfaction in this context is, what does it tell us about COVID-19? What does it tell us about SARS-CoV-2? And how can we use it to our benefit? So the importance of the nose in COVID-19 became apparent quite early. I think, so Scotty mentioned this, but my specialty within otolaryngology is something called rhinology, where we are subspecialists who concern ourselves with diseases of the nose and the sinuses. And we do medical management, but we also do all of the surgery on the nose and the sinuses. And that also includes anterior skull base surgery, where we can do surgery on the anterior skull base through the nose. Now, early on in the pandemic, there were a lot of concerning reports about rhinologists, sinus surgeons contracting COVID-19, seemingly in correlation with their work directly in the nose. And then there was a couple of studies that came out in New England Journal of Medicine and JAMA, which showed that the viral load detected in the nose seems to be quite a bit higher than what's detected isolated from the lungs, from bronchoalveolar lavages, et cetera. So this really started to, very early on, tell us that the nose was important with respect to COVID-19 and in some ways may be the epicenter for infection. So before we talk more about the nose and about olfaction, it's good to review nasal anatomy. For you guys, this might be the first time you're looking at it and thinking about it. When we think about the nose and the anatomy of the nose, we're typically thinking about some structures called turbinates, which are these outcroppings that come out from the lateral nasal wall. They have spaces underneath them, which we refer to as a meatus, and each meatus is important because important structures drain there. The function of these turbinates is in some ways unknown, but there's some hypotheses, for example, to heat and humidify the air that we breathe in. And then the other structure that we often think about when we think about nasal anatomy is the septum, which is the wall that separates the left side from the right side. And you guys have probably heard of people having a deviated septum. And that's what we're talking about. So what better way to get to know the anatomy than to see it up close? So here is something that we do in the office called a nasal endoscopy, where we look in the nose with a scope. So we're going to look in the right nasal cavity, and going in, you can see the septum off to the right here. And this is the inferior turbinate and the inferior meatus below it. This is the middle turbinate, a little higher up, a little further back, and the middle meatus below that. Hard to see the superior turbinate and superior meatus on an endoscopy. Sometimes you can, but often it's a little bit of a squeeze and can be a bit of cause a little bit of discomfort, so we don't always see it. But this is a nice view of what a normal nose looks like. So the nose is our interface with the outside world, at least when it comes to aerosolized agents, antigens, pathogens. Greater than 90% of the air that we breathe in passes through the nose. And depending on what kind of trajectory, and this is a figure from a really nice fluid dynamics study looking at airflow through the nose. And depending on the trajectory of aerosols and the air entering the nose, you can see that particles will deposit all throughout the nasal cavity, although I'll point out the major structures on which particles, for example, virions, may deposit: the inferior turbinate and this middle turbinate over here. But you can see that in some cases, those particles can get even further up and directly deposit into the olfactory cleft and olfactory groove. So let's talk about anatomy as it relates to olfaction. The olfactory nerves enter the nasal cavity through the cribriform plate, and they in large part are, and the cribriform plate is sort of located centrally, right above the septum, and these nerves come down through the cribriform, get onto the septum, but also onto these turbinates that attach way up high on the skull base. The olfactory epithelium is this region where these olfactory sensory neurons come down and are located on these turbinates as well as the septum. And it's this area that's about 2 centimeters in length and maybe a centimeter in width. This is why when we do surgery in the nose, anterior skull base surgery, we try to avoid doing any work on these structures within a centimeter of the skull base, because if you do that, you can affect the patient's sense of smell. So this is a sagittal cut where you can see through a cadaver specimen where you can see these turbinates and where these olfactory sensory neurons may be coming down. This is a coronal cut through a CT scan, just to give you a sense of where the cribriform is and how it relates to the septum, as well as turbinates, for example, this middle turbinate over here. So when we look at, or when we think about the olfactory epithelium, I tend to think about it in terms of there are cells of neuronal origin as well as cells of non-neuronal origin. Cells of neuronal origin, of course, are these olfactory sensory neurons. We'll talk about these more in just a bit, but these terminate in the nasal cavity on one end, and then on the other end terminate in the olfactory bulb, which I'll talk about more in just a bit as well. These exist in mature and immature forms. So there is constantly some degree of regeneration of these cells from the immature olfactory sensory neurons. There are precursor cells, these globose basal cells, that can differentiate into immature sensory neurons and then progress towards mature sensory neurons. So again, this is not a static structure. There is some, at baseline, there is some degree of regeneration. In terms of non-neuronal cells, the major cells we're talking about are these sustentacular cells. I'm going to call them supporting cells to make it easier on myself. Supporting cells also include these microvillar cells. These cells essentially provide nutrients. To simplify things, they provide nutrients, they detoxify the environment, and in that way support the olfactory sensory neurons. Bowman's glands produce mucus that coats the olfactory epithelium, and that mucus is necessary for carrying and capturing these odorant molecules that reach the olfactory epithelium. This component of the olfactory epithelium also is constantly being regenerated via these horizontal basal cells, which are stem cells that can differentiate into all of these different non-neuronal cell types. So when we think about regeneration of the olfactory epithelium, again, this is not a static structure. It can regenerate, and it does regenerate on a regular basis. These horizontal basal cells are the multipotent stem cells that essentially lead to regeneration of all of the other cell types. And the globose basal cells, these are really the neuronal precursors in the olfactory epithelium. So we know a lot about olfactory physiology, and I think one of the really cool things about there's a lot of cool things about olfaction, but one of the coolest things about olfaction is the fact that these odorant receptors comprise the largest group of genes in the human genome, which I think is really interesting. So in humans, there's at least 339 active odorant receptor genes. And each one of these olfactory sensory neurons expresses only one of these odorant receptors. So you essentially have to have at least one olfactory sensory neuron for each odorant molecule in order to be able to detect it. And in fact, we have many olfactory sensory neurons for each type. But again, what's important to know and understand is that each neuron expresses only one odorant receptor gene. And then each of these sensory neurons that detects a particular type of odorant molecule will then synapse into the olfactory bulb in a structure called a glomerulus. And each glomerulus receives input from olfactory sensory neurons that only detect one particular odor. And then what's neat is that there's actually a spatial map within the olfactory bulb too, where glomeruli that detect similar odorant molecules, and that's typically based on what kinds of side chains, again, going back to organic chemistry, you guys are a lot closer to it than I am, but what kinds of side chains these aromatic molecules have. But these glomeruli cluster together based on the similarities in terms of the kinds of odorant molecules that are detected. And just, kind of a very neat thing is that these zones of glomeruli that detect like molecules, they translate actually to functionally translatable entities. So for example, in mice, there is a zone where there is a cluster of glomeruli that detect odorants related to fear stimuli. So for example, you can knock out these odorant receptors and mice will not be able to detect odorants from a cat. And so the mouse will have absolutely no fear from a cat. And this is a really neat picture I found online demonstrating that. So just a very interesting and cool structure and physiology to olfaction. So moving away a little bit from physiology and talking about how do we assess olfaction in patients, there's a couple of different ways. And so the main two ways of detecting olfaction are subjective and objective measures of olfactory function. So subjective is essentially just asking the patient to tell us how his or her sense of smell is functioning. We can do this on a visual analog scale, which is essentially just like a classic visual analog scale might be like a 10 centimeter line on which a patient draws a little X, and how far along that line the X is tells us in relation to the overall 10 centimeter line how well their sense of smell is. You can think about it on a scale of 0 to 100, 0 to 10. Likert scales are discrete scales where a patient might say, good, or, terrible, not so good, okay, good, great, something like that. That would be considered a Likert scale. But we can ask patients to use these kinds of metrics to tell us how good or bad their sense of smell is. There are objective measures of smell and olfaction. So one of the classic tests, and this was developed in the US, and which might be why we use it a lot more here, is called the smell identification test. It used to be called the University of Pennsylvania smell identification test because that's where it was developed. It is 40 items. It is a scratch and sniff. It's actually on this prior image here. The patients will scratch a little, I don't know, scratch and sniff on these in this booklet, and they'll smell it, and they'll have 4 options that they choose from in terms of what it is. Essentially, asking patients to discriminate and identify what the odor is. And they have to answer every single one of these questions. And the reason for that is, by chance, you expect patients to get approximately 10 questions correct, right? So 4 options by chance, 1 out of 4, so 10 out of 40. The reason for that is actually you can detect when there's malingering, because essentially no one should ever score 0 out of 40. The odds of scoring 0 out of 40 is virtually it's virtually impossible. So they always have to answer all of the questions. And then there's normative values based on age. You can see on this graph here. So you can see that naturally, as one gets older, one's sense of smell also diminishes. So you have to take that into account whenever you are assessing olfaction objectively. So I mentioned that the smell identification test detects discrimination, one's ability to discriminate odors, but this is another system for objectively measuring one's sense of smell. It's called the Sniffing Sticks. It was developed, I believe, in Germany. Tends to be used a lot more frequently in Europe, but it detects 3 different components of olfaction. Threshold, so your ability to not just smell something, but how strong does it have to be for you to be able to smell it? Discrimination, can you distinguish a particular smell from other smells? And then just simply being able to identification, being able to identify what an odor is. And again, for this particular test, 16 items, and you have to guess on each. And that's sort of, a built-in quality control to make sure that patients aren't malingering. So one of the common complaints, or one of the physiologic functions of olfaction, is as it relates to the flavor of food. Often patients will refer to it as taste, but really it's the flavor of food. And flavor is really a combination of your ability to taste those basic senses of sweet, salty, bitter, sour, umami. It's a combination of that. It's a combination of olfaction, your ability to smell the food. And then it's also a component of flavor is something that's called kinesthesis. So your ability to perceive texture, temperature, acidity, which you kind of put into pain in the pain category, but it's those kinds of sensations as well. Each carried and delivered to the central nervous system through different neuronal pathways. Now, I'm not going to get too much into taste and kinesthesis tonight, but I will mention that patients with COVID-19 seem to actually very specifically have dysfunction as it relates to taste. Again, the ability to sense sweet, salty, bitter, etc. This is out of a recent study which showed that when you ask patients about this subjectively, compared to before COVID-19, patients during COVID-19 definitely exhibit and experience a decrease in that sense of taste, not flavor, which is what we're talking about with respect to olfaction. So there seems to be some dysfunction related to taste that's beyond and outside of the realm of what you would expect from olfaction. You can objectively measure one's ability to taste, again, sweet, salty, bitter, etc. And there's been a couple of studies out now looking at it, and there does seem to be some patients who, again, are unable to taste certain tastes during COVID-19. So in this paper, 50% of patients were able to taste all four of these modalities of taste, whereas in 22% of them they were missing at least one, in 15% missing at least two, and so forth. This was a recent study out of Switzerland, actually a group that we've worked with in the past, where they use these taste strips in COVID-19 patients, and they also found that patients had lost some of their specific senses of taste. So for example, they found that sour was the most frequent sense of taste that was lost in these patients. Scotty, you have some questions.
Yeah, Dr. Sedaghat, there's a question from one of the students. What's the approximate rate of false positives when using these olfaction tests for COVID-19 diagnosis?
We are going to get into that. So let's save that for later after the lecture if I haven't answered that.
Sounds good.
So I also mentioned that chemesthesis is a component of flavor as well, which is, and again, flavor is what we're going to be talking about in terms of what gets affected by COVID-19 due to olfactory dysfunction. But a part of flavor also is chemesthesis. Again, your ability to sense textures, temperature, pain, acidity, things like that. That's going to be carried by the trigeminal nerve. And again, distinct from olfaction, which is mediated through the olfactory nerve, and taste, which I didn't mention before, but mediate with taste, your ability to taste sweet, sour, bitter, etc., is mediated through the facial nerve as well as the glossopharyngeal nerve, and to some extent, lesser extent, to the vagus nerve. So these are all different cranial nerves that are carrying signals related to flavor. So subjectively, patients also notice that during COVID-19, compared to before COVID-19, there is a diminishment in their ability to sense chemesthesis. So let's talk a little bit about olfaction as it relates to taste, or again, flavor. We're going to get out in the subsequent few slides. We'll talk about sort of all of these neuronal pathways that converge to help us with our sense of flavor. But the type of olfaction that really impacts your ability to sense flavor of food is what's called retronasal olfaction. Orthonasal olfaction is when you smell things and these odorants go through your nostril and go up to the olfactory epithelium. Retronasal olfaction is these odorants go around the soft palate and go up to the olfactory epithelium in that manner. There seems to be something different about retronasal olfaction than orthonasal olfaction. And this is commonly, at least in the field, it's illustrated with the example of Limburger cheese. I'm not like a big cheese aficionado, but apparently this stuff tastes, or it smells horrible, but it tastes really good. And the difference between retronasal and orthonasal olfaction is thought to be what differentiates, or it explains this paradox of this cheese smelling horrible but tasting really good. So just Scotty, give me a second. I'm looking at the time here. It looks like we're about halfway through our time. Is that correct?
Yeah.
Okay.
6:25 about.
Okay, all right. We may go a smidge over, but I'm gonna speed up some of this just in the interest of not taking up your guys' entire evening. We can talk all evening about this stuff. So I'll summarize the next few slides by saying that in comparison to olfaction, where the signals are coming from the olfactory nerve and really essentially just getting routed straight to the olfactory cortex, Flavor here on the right is a much more complex phenomenon carried by multiple cranial nerves and integration of signals from all of these cranial nerves and different parts of the brain. So we'll skip this. All right, so let's talk about olfactory and taste dysfunction in COVID-19. So it's an early symptom of COVID-19. This is a paper that came out earlier in the pandemic, which showed that, and I highlighted this, this is a multi-center study, and I've highlighted the pertinent point here. 27% of these patients experienced anosmia before any other symptom. So imagine that 25% of these COVID-19 patients could have been identified by simply screening for decreased sense of smell or anosmia. This is a systematic review looking at the timing of olfactory dysfunction in these patients. So about 20% of these patients, 20% of COVID-19 patients had smell loss before any other symptom, 28% concomitant to other symptoms, and about 54% after other symptoms. So again, up to 50% of these patients will experience their olfactory dysfunction as the first or one of the first symptoms of COVID-19. This is from a study that we did out of Switzerland, where we specifically asked patients what day in their COVID-19 disease course they experienced smell loss. We found that of all comers, it was the first symptom experienced in 8.7% or 15% of patients who experienced olfactory dysfunction. When it occurred at a median of 3 days into the disease course. So again, a very early symptom. And you can tell from this histogram plot, the COVID-19 disease course can drag on for a couple of weeks or longer. And when it happens, though, you can see this happens very early on in these patients. The vast majority happening before a week. And like I said, a median of 3 days into the disease course. So what's the prevalence? So this is one systematic review that came out looking at 3,300 patients that had been published at that time, reporting a prevalence of about 50%. Now you can already see by looking at the studies that were included in this systematic review, some trends which I'll touch on later on, that for example, in China, the prevalence was quite low. Singapore, prevalence was quite low. Let's see, there's another one. Iran on the lower side. There may be some geographic variation to the prevalence of olfactory dysfunction. Does this reflect cultural differences in terms of patient reporting? Is it a reflection of genetics and how COVID-19 or SARS-CoV-2 interacts with the body? We're not sure, but prevalence is reported to be around 50%. This is a more recent systematic review, increasing the number of patients that were included by an order of magnitude up to about 30,000, and reporting very similar prevalence. About half of these patients with COVID-19 report some subjective, actually, I guess this one also reported objective, but bottom line is about 50% of these patients have some smell loss. There is a disparity, and that's why I corrected myself on the last slide. There's a disparity between subjective and objective smell loss. So in the middle portion of this graph or from this systematic review, this looks at subjectively reported smell loss, with patients reporting somewhere between 45 and 50% of them having a prevalence of smell loss. Now, if you measure olfactory function objectively, that prevalence goes up quite a bit, up to about 75%. So this is very interesting, where patients have olfactory dysfunction, but they don't necessarily notice it or report it. This is yet another study looking at the divergence of subjective and objectively measured olfactory dysfunction, where there were 18 patients with objective anosmia. These are all COVID-19 patients. 18 of them have objective anosmia, yet only 10 out of the 18 are reporting that they have complete smell loss. 20 with objective hyposmia, and 50% of them reporting that they notice their smell loss. This was a paper that came out early in the pandemic and is still sort of recognized as the first and classic example of this. This is a study that came out of Iran looking at 60 COVID-19 patients versus 60 healthy control patients. Now you can see in, Scotty, can you guys see my cursor? I just want to make sure you can see my cursor on these slides. Is that correct?
Yeah, we can see your cursor, but one thing that might make it a little bit easier to highlight is if you go to the bottom left of your screen and
Okay.
click on the pencil,
Ah, there we go. And
and
then,
then there should be a laser. Yeah, the laser pointer.
sweet.
Yeah.
Okay, great. Oh, this is fantastic. All right. So of these 60 patients with COVID-19, only one out of the 60 had objectively normal smell function. The rest of them fell somewhere between mild to severe hyposmia. They call it microsmia, but same thing, hyposmia, with 15, so 25% of them having anosmia, complete loss of sense of smell, in comparison to the controls where the vast majority either had normal sense of smell or a few had some mild hyposmia. Now, again, 59 out of 60, like 98% of these patients, these COVID-19 patients, had objective smell loss, and yet only 21 out of 60 of them complained of actual smell dysfunction. So very great disparity there between the subjective and the objective. Taste dysfunction has also been reported. This is, again, a systematic review looking at both objective as well as subjectively measured taste dysfunction. And prevalence seems to fall right in line with what we have found with olfactory dysfunction. So I think in large part, a lot of this, at least the subjective taste dysfunction, is going to be actually dysfunction in one's ability to sense flavors. But as I noted before, there seems to be at least some degree of objective taste dysfunction as well, inability to taste things like sweet, salty, sour, bitter, etc. So when we talk about olfactory loss in COVID-19, what kind of severity of smell loss are we talking about? And early on in the pandemic, people went back and forth between anosmia, hyposmia. Hard to know what was happening. So we actually studied this in one of our papers, looking at severity of these different symptoms that patients experience. And looking at smell loss here, you can see the vast majority of patients who experience smell loss are losing it in a very severe manner. And that's very similar to what we see with taste loss as well. 81% of patients experiencing smell loss reported to be severe, and that's about 2/3 of patients experiencing taste loss reporting it to be severe. So when it happens, it is not subtle, especially with the olfactory dysfunction. These patients get hit hard. There is a very tight correlation between patients reporting subjective smell loss as well as subjective taste dysfunction. Again, why we think that probably the majority of taste dysfunction is probably more like flavor dysfunction. Modifiers of smell loss. So I mentioned earlier, I pointed out earlier in some of those systematic reviews that there seems to be some geographic distribution in terms of, or some geographic impact in terms of smell loss, with North America and Europe reporting higher prevalences in that 50% ballpark, whereas in Asia, it tends to be lower. Now, some of these studies from Asia came from early in the pandemic, where where the studies were retrospective chart reviews. And early on in the pandemic, patients weren't necessarily, or maybe the physicians interviewing the patients weren't focusing on olfactory dysfunction, so maybe it wasn't documented as well in those charts. But some of this seems to hold up in subsequent studies as well. So again, is it a geographic thing? Is it a genetic thing? Is it just a cultural thing as well, where patients don't necessarily, since we know that there's this difference between or disparity between subjective and objective smell loss, is it a cultural thing where people don't necessarily focus on reporting it? Are there risk factors for developing olfactory dysfunction? We and others have found that female gender seems to be associated with having olfactory dysfunction and more severe olfactory dysfunction. Younger age is a risk factor. One study suggested that there's a negative association with hypertension, and there's a positive association with diabetes. Not so much a risk factor, but an interesting association that has popped up is that whether milder COVID-19, whether olfactory dysfunction tends to happen in milder COVID-19. So this is a systematic review looking at patients with different degrees of severity of symptoms and olfactory dysfunction. And you can see the patients with severe symptoms have a lower prevalence, around 31%, compared to patients with mild to moderate symptoms having more like 2/3, 67% prevalence. This is a study looking at serum IL-6, which is also a marker of COVID-19, or could be a marker of severity of inflammatory disease. COVID-19 or lower serum IL-6 is associated with milder disease course. So the patients with anosmia had lower IL-6 serum levels. So again, maybe indicating that anosmia is associated with COVID severity. This is a different study looking at, and this came out of Iran as well from this Moeen group, looking at COVID-19 disease severity and how they tested on objective measures of olfaction. So different than what we were talking about before that was subjective. Is it possible that when you have severe COVID-19, you have bigger fish to fry and you're not really so worried about reporting your olfactory dysfunction, lower on the priority list, and you're more focused on being able to breathe, and that's why the reporting isn't quite there? In this study where they used objective testing, there was no difference between COVID-19 disease severity. In our study where we looked at different symptoms across the board for COVID-19, we saw maybe a hint of an association between the severity of olfactory dysfunction and shortness of breath. Again, indicating that maybe there is some association with olfactory dysfunction and greater disease severity. At the end of the day, what I think probably is going on is that there are definitely these milder forms of the disease where patients just have some olfactory dysfunction. And then there are these more severe forms where patients essentially have everything: smell loss, but also shortness of breath, fever, cough, etc. This is another recent study that looked at association of olfactory dysfunction with other symptoms. They found that it was OD was associated with nasal congestion and diarrhea, maybe again an indicator of more systemic disease process. So moving on to recovery. This is a nice study looking at several thousand patients out of Korea and tracking their recovery of olfactory dysfunction after COVID-19. And you can see here, the vast majority of these patients not only regain their sense of smell, but it happens very quickly on the scale of 7 to 14 days. And you can see this also here in this histogram plot of recovery of their sense of smell. Again, the vast majority happening within 2 weeks. Now, there are multiple peaks to this distribution, and we'll talk about that a little bit later on. But for the most part, and Scotty, what we're talking about early on before the lecture, why we haven't necessarily needed to institute a COVID-19 olfactory dysfunction clinic is because thankfully most of these patients get recovery and they get it quite rapidly. So you guys had your pathophysiology and virology lecture already, so we won't get into that here, but suffice it to say that the spike protein of the coronavirus is very important. And in this case, the receptor for the spike protein is ACE2, and there's this co-receptor, this transmembrane protein, I think it's a serine proteinase, TMPRSS2, that are very important for the virion's ability to infect a particular cell type. So when you look at where ACE2 is expressed, it actually seems to be expressed most highly in the nasal epithelium. And the further you move down the airway, the less and less that ACE2 is expressed. Now, not to say that it's not expressed, it's just that it's expressed less and less and less as you move down the airway. So the question is, well, what kinds of cells is ACE2 being expressed in? And there have been some studies that have gone back and looked at single cell RNA sequencing data that have been previously published, specifically looking for ACE2. And we can see that the expression level is really, really high in goblet cells, so the cells that produce mucus in the nasal cavity, as well as the ciliated cells in the respiratory epithelium. And again, as you move down into the lower airway, expression of ACE2 diminishes. This was an interesting study, again, looking at that single cell RNA sequencing data, but looking at it from the perspective of not just ACE2, but also receptors for other airway viruses, right? So again, we can see the pattern of expression of ACE2 in the cells of the airway, both the upper and lower airway. This is a gene that I guess is the receptor for this endemic coronavirus. And you can see that, again, probably the highest level of expression is within the nasal cavity. In contrast to influenza, where you can see expression of the receptors for influenza very different in terms of their distribution within the airway. And then MERS, this other coronavirus epidemic, highly fatal, where its receptor was predominantly expressed in the parenchyma of lungs. So again, going back to early observations with the higher viral loads being detected in the nose as opposed to the lower airway, it makes sense, right? So the cells that express the highest levels of the SARS-CoV-2 receptor are in the nose. So that explains and may explain why we detect the highest viral loads in the nose, and potentially why us surgeons working in the nose early in the pandemic may have been at the highest risk of contracting COVID-19, at least as it relates to otolaryngologists in general. This phenomenon is the case, and it is true in other animals as well. There are different animal models for SARS-CoV-2 and COVID-19, including the ferret and the cat, where we see that after infection, viral loads in nasal tissue seems to be highest compared to other areas in the airway, oropharynx, trachea, and lungs. And the same is true. So this was in cats, and this is also the case in ferrets. So again, looking at all the cells that comprise the olfactory system, from the epithelium up into the olfactory bulb, there are single-cell RNA sequencing experiments that have been done looking at these cells, looking at expression of genes in these cells. And we have a decent idea of which of these cells expresses the highest levels of ACE2. So in the olfactory epithelium, well, let's start with the olfactory bulb. Very little, essentially no ACE2 is really identified or detected in the cells of the olfactory bulb, with the exception of these pericytes that surround the vasculature that is entering the olfactory bulb. Within the olfactory epithelium, it's essentially every cell type except for the olfactory sensory neurons, which seem to be expressing ACE2 at least at detectable levels. This is more data from these single-cell RNA sequencing experiments. This is what's called a UMAP figure, which shows essentially clustering of cells that express similar, or that have similar gene expression profiles. And so essentially these are very similar cells. You can see the cells that are expressing, so the cells that are respiratory epithelial cells, supporting cells, these sustentacular cells, Bowman's gland cells, you can see where they all cluster. And then you can see when you overlay ACE2 expression in these cells, that this corresponds also with these respiratory epithelial cells as well as these supporting cells. In contrast, when you pull out the cell populations that are indicative of either immature or mature olfactory sensory neurons, and you can look at expression of markers for those immature or mature olfactory sensory neurons, you see absolutely no expression or no detectable expression of ACE2 or TMPRSS2. So more data along those lines, which I'll skip in the interest of time, but just to re-emphasize and to re-illustrate the fact that in terms of detection of expression of ACE2 and TMPRSS2, this seems to be most highly detected in these supporting cells in the olfactory epithelium. This is a nice figure from a golden hamster COVID-19 disease model where they're looking at the olfactory epithelium, doing co-staining for SARS-CoV-2 as well as a marker for olfactory sensory neurons. And you don't see really any overlap. You can see the red and the green very crisply but distinctly. In contrast, when you stain for SARS-CoV-2 and you stain for a marker of those supporting cells, cytokeratin 18, you see more overlap. So you see that red is not as bright anymore. You can see the overlap with the green over here. So then there are different models for how COVID-19 may cause olfactory dysfunction. The fact that the infection is so dominant in the nose, and we've already established the fact that there's so much viral replication in the nose, there can be edema in the nose. Think about what happens when you get a cold. Your nose swells up. That swelling can also occur in the olfactory cleft. That olfactory cleft is tiny. It's a very narrow slit. And as we talked about earlier, I showed that figure of distribution of particles and where they deposit when they enter the nose. Even if you don't necessarily get viral deposition into the olfactory cleft. If you get viral deposition on that middle turbinate, which is a common place where deposition occurs, viral replication can make its way up into the olfactory cleft and groove and cause inflammation that can cause that area to swell shut and cause what's called a conductive olfactory loss. Odorants simply cannot get up to the olfactory sensory neurons because that area is swollen shut. You can get indirect infection of those supporting cells, loss of those supporting cells, and then if they are not able to support the olfactory sensory neurons, could that lead to dysfunction or death of the olfactory sensory neurons? There can be inflammation in the olfactory epithelium. Again, a consequence of active infection in the olfactory epithelium, and inflammatory cytokines, again, causing dysfunction of the olfactory sensory neurons. And again, is it possible that there's direct infection of those olfactory sensory neurons that directly causes death of those neurons? And then finally, maybe a lesser cause, but certainly a possibility. There certainly is systemic COVID-19, systemic distribution of SARS-CoV-2. If those virions infect the parasites that are surrounding the vasculature that is feeding the olfactory bulb, cause dysfunction, clotting of those vessels, and then essentially cutting off the blood supply to the olfactory bulb, could that cause olfactory dysfunction? That's certainly a possibility. I am going to skip some of the evidence in terms of each of these possible mechanisms of olfactory dysfunction. Again, just in the interest of time, because we're cutting it close. Suffice it to say, you guys will all have access to this lecture and my slides, so you can flip through this at your leisure, but I'll just leave it at there is evidence for each of these possible mechanisms of action for COVID-19 to cause olfactory dysfunction. So conductive losses with an MRI, with MRIs showing swelling in the olfactory cleft, inflammatory markers being elevated in the olfactory epithelium of patients with COVID-19 compared to controls, evidence of direct infection of those supporting cells in the olfactory epithelium, as well as some possible evidence of infection of olfactory neurons. Now, even though we can't detect ACE2, is it possible that there are other co-receptors that are used that may be expressed in olfactory neurons? Or is it possible that ACE2 is expressed at such low levels that we just can't detect it? I'll flip back to this slide here where you can see SARS-CoV-2 staining in essentially across the board in the olfactory epithelium. Now, some of those single-cell RNA sequencing studies will tell you that there's only about 4 to 5% of these cells that express ACE2. And looking at this, I would tell you that's probably not the case. So, modern genomic methodologies are really fantastic and are telling us things that we've never been able to see or know before, but probably not picking up everything. So it is certainly possible that some of these olfactory neurons are expressing ACE2 and we're just not able to detect them. So again, going back, there's evidence for each of these mechanisms of action. And I'll bring it back and I'll translate it to what we see in terms of recovery. My thought, and probably a lot of individuals, experts' thoughts on this, is that recovery is probably an indication of which pathophysiologic mechanisms are occurring in the patient. Probably things like edema, congestion, a conductive block at the olfactory cleft, that's probably going to recover and resolve fastest. And that's probably what happens in the majority of cases. Now, when you start talking about infection of supporting cells causing dysfunction of olfactory sensory neurons or death of olfactory sensory neurons, that's when you start to get further and further out on the recovery curve. And the more severe and dramatic that infection is at the olfactory epithelium is probably an indication and is reflected in how long it takes for recovery to occur, if ever at all. So I'll end by just talking briefly about the clinical significance of olfactory dysfunction in COVID-19. So there's, of course, the quality of life impact. We've actually done a few studies on this outside of COVID-19, but in for other reasons. What we've actually found with respect to quality of life and why I focus so much on food early on is that it really seems to be that patients, they notice this most when it comes to their ability to eat food and not just even eat and experience the flavors of food, but there's so much quality of life that's associated with social interactions that we experience over meals, with friends, with family. And that seems to be where the biggest hit comes with respect to olfactory dysfunction in patients. Someone asked earlier about the accuracy. How well does olfactory dysfunction identify patients with COVID-19? What I'll say is that the studies all seem, for the most part, seem to indicate that it is a very specific marker of COVID-19, not a very sensitive marker. So the fact that only 50% of patients experience COVID-19, and of those patients, 50% of them experience it as an early marker, will tell you that if you're going to screen patients, you're only going to catch at most about 25% of patients with COVID-19. Now, if you take the other approach and say, well, of the patients who have smell loss, and in particular are showing up with anosmia, how often are those patients going to have COVID-19? And that is a very, very specific marker of COVID-19. And the vast, vast majority of those patients are going to have, well, that's not true. It's a very specific marker. So if you don't have the anosmia, you're very likely to not have COVID-19. But so the positive predictive value is about 50%, and the negative predictive value is quite high, again, indicative of or reflecting the specificity. This is another study, again, looking at a very large cohort of COVID-19 patients, where they found, this is actually interesting, they found a little bit different, where they found if you use a cutoff, they measured smell on a scale of 0 to 100, cutoff less than 13. You identify these patients with 85% sensitivity, lower specificity. This is a little bit different than what some other studies have shown. This is another study looking at EHR medical records at the Mayo Clinic, where smell loss was the -1 predictor of patients having COVID-19. So this odds ratio or rate ratio, 27-fold higher odds of having COVID-19 than not having COVID-19. And these are in patients who are tested for it. So patients with upper respiratory tract infection symptoms. This was, again, the #1 predictor. Not perfect by any means, but again, a highly, highly specific marker of COVID-19. This is a study showing that in patients who were tested for COVID-19, presenting with upper respiratory tract infections and being tested, of the ones who were, of the ones who were the false positives, they were the ones who were complaining of nasal blockage. So before COVID-19, everyone had good nasal airflow. After, when they presented with these upper respiratory tract infections, the ones who did not have COVID-19 tended to be the ones who were presenting with nasal congestion. So anosmia, smell loss in the absence of other nasal symptoms seems to be very indicative and a very specific, again, a highly specific marker for COVID-19. Scotty, you mentioned this study earlier on that we did, and I'll touch on it briefly. We actually found that in patients with COVID-19, in the midst of COVID-19, these patients had dramatically increased severities of depressed mood and anxiety, reflected by PHQ-2 and GAD-2 score. These are patient-reported outcome measures for depressed mood and anxiety, respectively. We found that the only predictors as it relates to COVID-19 symptoms for having depressed mood was their sense of smell and sense of taste. Same thing for anxiety. The only COVID-19 symptoms that were predictors of anxiety were decreased sense of smell and taste, which was very surprising to us because I almost didn't do this analysis because I thought it was going to be so trivial that those severe symptoms of COVID-19 would be what triggered depression, depressed mood, and anxiety in these patients. I would think that if you were experiencing you would be experiencing shortness of breath. That's what would be contributing to your anxiety and depressed mood. And yet that was not at all what we found with this study, which was really interesting. And this is what made us hypothesize early on that, is this an indicator that SARS-CoV-2 could be using the olfactory pathway to cross into the central nervous system, or at least somehow affect the central nervous system, whether it's through inflammatory mediators or direct viral inoculation of the central nervous system to affect emotional function. Because at the end of the day, psychological health, psychological function, emotional function, that is a central nervous system symptom and a reflection of central nervous system pathology. So we hypothesized that was a possibility. This is a recent study that was published, which showed that, yes, you detect a lot of virus in the olfactory mucosa, but you will actually detect it to a lesser degree, but you can actually detect it in the central nervous system as well. So is it possible? Jury's still out. I mean, there is definitely some evidence out there that virus can cross over into the central nervous system and affect the central nervous system. Again, whether it's direct infection or inflammatory effects, yet unknown. So, and this is again a slide that I showed earlier in terms of electron microscopy evidence of direct virus infection in the central nervous system. So there are treatments for this. There's what's called olfactory training, where you essentially rehab for your sense of smell, smelling these, and the way that it's described in the literature and recommended is using these 4 scents, smelling them, and essentially triggering your memory and thinking about what these things smell like, so that you not only activate your olfactory nerves, but you also link those nerves and the activation of those nerves to your memory centers to sort of complete that loop. So there are a few studies out there about treatments in terms of topical steroids. Suffice it to say, these studies are done in small cohorts, and I will summarize that by saying the treatments exist for these persistent cases. Probably the best treatments are olfactory training, topical intranasal steroids. And I'll also end by sort of just concluding by saying this is a very common symptom of COVID-19. 50% of patients will experience olfactory dysfunction in COVID-19, and 50% of those, so a quarter of all COVID-19 patients, will experience olfactory dysfunction as either the first or one of the first symptoms. So it is a very important symptom from the standpoint of public health and catching these patients before they go out and spread the infection around. It's important to note that the vast majority recover, And the occurrence as well as the recovery of olfactory dysfunction in these patients is likely dependent on pathophysiology. So with that, I will thank you. Sorry, I went over a little bit, but I think these slides will be available to everyone if they want them, and the video will be posted, right?
Yes, absolutely. And thank you so much, Dr. Sedaghat. Really, really fascinating lecture. So now I encourage the students, because I know you had questions before the lecture, and I'm sure now you have even more questions. So I really encourage you guys, if Dr. Sedaghat can spare a few minutes, unmute
Sure.
yourselves and either ask the questions on video, or if you'd rather ask in the chat, that's fine as well, but would really welcome your questions. All right, so
Yeah. Do
can you
you want to
see
read
them,
them off,
or?
Scotty?
Yeah, I can
I
read them
see.
off.
I see
So
abbreviated. I see abbreviated comments.
yeah, absolutely. So Rishi had a question. He said, "Do you see an at-home smell test being used as a replacement for other at-home detection tests, such as a saliva test, given the high percent of patients who exhibit loss of smell?"
So it will not replace an at-home smell identification test or smell olfactory function test. Will not replace a test that will detect viral antigens, viral RNA. And the reason for that is it's just not sensitive enough, right? It's a great screening tool, but it's not sensitive enough. So if someone has the olfactory dysfunction, it triggers us to do more workup and to quarantine them. But if someone doesn't have the olfactory, there are lots of COVID-19 patients who don't have the olfactory dysfunction. At least 50% of them aren't going to have it at all. And then another 25% of them will get it, but it's going to be later in the disease course after they've already gotten the fevers, the headaches, the shortness of breath. So we're only going to catch about 25% of patients if we want to use it as an early screening tool. So I don't see it replacing at-home antigen tests. But again, I think it's just using subjective complaints or subjectively noticed olfactory dysfunction will catch a reasonable number of these patients.
Hannah has the next question. So she's wondering, is there any evidence of permanent loss of smell from COVID-19 due to infection of basal cells or any other cell types?
So again, remember that we've only known about COVID-19 for about a year now, right? So we still don't know who's going to be permanent and who's not, because even after post-viral olfactory dysfunction, post-viral anosmia that patients can get after the common cold, there are some patients who a year or two will recover their sense of smell. So we still don't know who's going to be permanent and who's not. Now, you saw from that figure that I showed in terms of recovery, already the vast majority of patients regain their sense of smell within 2 weeks, if not then by a month. So of that tiny fraction left over who have persistent smell loss for beyond a month, we just don't know how many of them are going to be permanent. And then in terms of understanding whether that permanent loss is due to direct virus infection of either the horizontal basal cells or olfactory neurons, that's really an impossible study to do in humans, right? We can't go into the nose of a patient with persistent smell loss and biopsy. Right, you can, but it's very difficult, and in particular, you'd have to do it in the middle of the COVID-19 disease course to actually catch viruses replicating in olfactory sensory neurons. So I think that's a tough thing to study. There are animal models. I showed you a slide from it was a golden hamster animal model for COVID-19, where they saw the vast majority of viral replication was occurring in the supporting cells. So jury's still out. Long story short, jury's still out in terms of whether we think that direct infection of olfactory sensory neurons is what causes permanent, if there is permanent, olfactory dysfunction in these patients.
Great. So Dr. Wazorek has a question. Dogs are known to be able to detect COVID-19 patients through smell. Is there any known mechanism to how they're able to do this?
Great question. I would have no idea. That would seem to indicate that the COVID-19 patients are emitting some sort of odorant that dogs can detect. So I have no idea what kind of odorant humans with COVID-19 might be emitting. Yeah, that's a good question. I don't know.
Aubrey actually had a question about the research that your group has published. So, does the depression and anxiety that you guys saw among COVID patients, does that resolve once sensory function is restored?
So we are still in the process of studying that. We definitely see that it decreases, at least preliminarily, it decreases over time. But we're working on establishing correlations between improvement in sense of smell and depression and anxiety. I will tell you that we've studied this, and others have studied this in other inflammatory diseases of the nose and sinuses, where as olfactory dysfunction resolves, you also see improvements in depression and anxiety, which occurs in other, like I said, other conditions as well, where you get loss of one sense of smell.
And building off that question, asked, um, when you were doing these studies on mood and other things related to COVID-19 olfactory loss, have you guys studied the neurotransmitters involved at all, or have you done any basic studies of these patients?
No, no, it's our personal involvement with this during the pandemic has really been to essentially use our expertise in the field to try to at least contribute something back and increase knowledge on the topic. My lab is really focused on studying inflammatory diseases of the nose and sinuses and studying chronic sinusitis. So we haven't really gotten into that here.
So Sasha is interested. Is there any reason for why some patients do not recover olfaction? So, although the majority do, what is going on with the subset that do not?
So there have been some studies that have looked at cadaveric specimens, and in these patients, you can see just blanket loss of olfactory sensory neurons. So that is probably the etiology of what happens. The question is, I think in our minds is what is causing that massive loss of olfactory sensory neurons? Is it the massive loss of supporting cells, which then leads to the loss of the olfactory sensory neurons? Or is it direct infection, inflammation, all of the above? We don't know. But the thought for patients who are going to have long-term, persistent, permanent smell loss is that it is likely due to massive loss of olfactory sensory neurons.
Another student had a question about your research into depression and anxiety with COVID-19. So, did you run into any challenges controlling for other outside factors from the COVID-19 pandemic that could cause depression and anxiety, like social isolation or reduced engagement?
Yeah, that is a great question, and no, we did not. Is it very possible that? So let's see. Could we make a conclusion about that from the data? If it was related to social isolation, all of these patients across the board were socially isolated, were quarantined. And we did not see an across the board increase in depression or anxiety. And, I think still it's hard to, and that certainly could play a role, but I don't know how that would confound the association we found between smell loss and depression and anxiety. It's certainly a possible other mechanism, additional mechanism, but I don't know that that would confound the relationship that we found. Does that make sense?
Yeah, absolutely. And Rishav, if you have any more questions, just put it in the chat about that. And then lastly, Ethan had a question. So he's heard about the cough test from MIT that can determine COVID-19 infection through the sounds of the cough. and that they're quite accurate. Do you think there's any relation between this and just loss of smell or taste?
Uh, it'd be a stretch for me to try to connect those two. It'd be a stretch.